Okay. So yes, I will be talking about a new method to image pain generators and give you some of our early clinical experience, although it's not that early anymore. I think we've done close to 500 patients now using this method. Um, in the United States, it's now reimbursable, so that's why it's starting to take off. Insurance is covering this study, so I'll share some of that. These are my disclosures. And now pain is now the most prevalent disease in the world. It passed the common cold in 2011. So we would say there are a lot of people suffering from chronic pain. And in fact, they think in America, it's close to 100 million Americans suffering from some sort of pain, whether it's headache or pelvic pain, spine pain, joint pain, like that. Almost 100 million, so almost a third of the country has some sort of pain. Now it's like I said, number one reason to see your doctor. It's the number one cause for losing days at work. One of the sad kind of statistics that I talk about is about 70% of those seeking medical attention don't achieve significant pain relief. So, majority of patients looking for management of their chronic pain are unsuccessful. And then we spend almost $1 trillion US in this country managing pain or suffering setbacks from pain, like lost labor. And then for imaging, we actually spend somewhere between 20 to $30 billion US to image pain. So, for example, we spend $1 billion alone in headache. And then low back pain is probably the number one reason. Somewhere around $10 billion is used to image back pain. So, a very, very big problem, one which we don't have good solutions. What I'll be talking about is giving some examples of, as a musculoskeletal radiologist, which is what I do a part of the week. I am a clinician and I uh, interpret MRIs and CAT scans, X-rays, so on and so forth in the musculoskeletal realm. And then I also do interventional procedures. So I'm injecting patients who have pain in locations that we think might help them. So we inject anesthetic and steroid, let's say in their facet joint or in their epidural space or in a shoulder joint to give them pain relief. But I'll show you some of the challenges I face with my standard of care practice, if you will. Then I'll talk about some how we're emerging this new method to image pain generators, and then give some clinical examples using how, when we use FDG or a radioligand to the sigma-1 receptor. So this is my ugly truth. Every day I have to deal with this, and I'm going to pose these as kind of questions to the audience, and you can, of course, answer them in your head. But I thought this might be an interesting exercise for you to understand the challenge it is to image pain. So this is a famous study done by Modic. Modic is a radiologist who described this modic changes that you may talk about on a lumbar spine or a spine MRI. One of the studies he did is a patient would present to the emergency room with back pain, and he'd ask those patients, can you get an MRI in the same visit? So they would get the MRI, and they qualified for the study if they had a herniated disc on the MRI, as well as back pain. So that's what entered the study. Then he said, okay, please come back 6 weeks later. I'm going to ask you, do you still have your back pain? And let's also re-image you with MRI, which is, of course, standard of care here, and see if that herniated disc disappeared or stayed there, and see if we can correlate the presence of your back pain with a herniated disc. So at 6 weeks, there are four possible outcomes patients can have. These four possible outcomes are listed here. Um, so the two kind of straightforward outcomes that you would expect at 6 weeks is that The patient said, my back pain is gone, and the repeat MRI showed that the herniated disc has resorbed. So most of the time, your herniated discs go back into that disc space and your pain goes away. Then the other outcome is you still have back pain at 6 weeks, and then your repeat MRI showed you still had a herniated disc. But then there are other outcomes that are a little bit puzzling. Uh, a patient would say at 6 weeks, I still have back pain, but when they re-imaged his spine, their herniated disc was gone. Or if at 6 weeks they said, yeah, my back pain is still there, but I mean, it's gone. My back pain is gone, but when you re-image his spine, he still had a herniated disc. So these last two outcomes are kind of confusing, but Modic wanted to know which of these was the most common outcome. Um, can you guess which one it was? When I talk to a real audience, most of the people say, "Oh, number three is the most common outcome, where you still have back pain, but the disc is gone." But actually, all of these outcomes were equally likely. So, as a radiologist, this is a little bit interesting, if not frustrating to me, because it looks like back pain symptoms don't necessarily correlate with the presence of a herniated disc. And every day I'm talking about herniated discs, but frankly speaking, I can't tell if that is really painful to them or not. And this study supports that. Here's another example. This was a large study done in New England area. They scanned patients with knee pain and without knee pain. They did MRI of the knee, and one of the questions or one of the issues they wanted to know was what is a major pain generator of knee? So the two most kind of thought of pain generators for the knee are arthritis and meniscal tears. So this study kind of controlled for everyone who had arthritis. So they were basically asking, okay, if you are 50 and above and you have knee pain, what are your chances of having a meniscal tear? It turns out it's 63%. So pretty high chance of having a meniscal tear if you're in your middle ages and you have knee pain. But they also asked, okay, if you have no knee pain, you're 50 and you're above, what are your chances of having a meniscal tear? Turns out to be 61%. So every day, probably 20 to 30 times a day, I am talking about these meniscal tears. But this study showed maybe the meniscal tear in some individuals may not be their actual pain generator. Why this is important is every time I talk about a meniscal tear, there's an orthopedic surgeon who's eager to do a surgery on that patient. And it's not surprising that some patients after this surgery don't do so great. Usually their pain may be still there. In fact, this was proven by a group in Finland. They compared um, arthroscopic partial meniscectomy to sham surgery. So about a little more than 200 patients volunteered for this test. All of them had knee pain and all of them had meniscal tears. And half of them had a meniscectomy using arthroscopy, and the other half had the arthroscopes placed into the knee, but no meniscectomy was done. And then they said, okay, let's compare the sham surgery to the actual meniscectomy. And as you're probably suspecting, there was no statistical difference between the meniscectomy group and sham group. So again, supporting a fact that maybe meniscal tears may not be the important source of pain in someone's knee with knee symptoms. And again, why this is important, there's, at least in America, it's a huge business doing these meniscectomies for tears. But in fact, we're finding evidence that it may be not really working as well as they think it should. Here's another example, lumbar spine MRI. Um, I'm asking you, as in the audience, these are two different lumbar spine images, the sagittal projection, and there's an image on the left, which is one patient, and a separate patient, a different patient on the right. My question to you is, who has low back pain and who is asymptomatic? Of course, this red arrow is pointing to an extruded herniated disc here. So maybe on the left, you would say this is a normal MRI where we have a very patent canal, and maybe that patient is asymptomatic. This one, we have a herniated disc, but it turns out both of these patients had 10 out of 10 back pain. So again, on a daily basis, maybe several times a day, even, I will find a normal MRI. Yet this patient came in with 10 out of 10 back pain. So I struggle as a radiologist, my report is not going to be very helpful for that patient. This one is, of course, a little more straightforward. We can maybe assume that that disc is the cause of pain, but even as we saw in the meniscal case, there are cases where herniated discs are not painful to the patient. So very unsettling experience that I have as a radiologist. And as I mentioned, I'm also a musculoskeletal interventionalist, so I do these spinal injections. Here's a patient who has quite a bit of narrowing in the lateral recesses here on MRI. And we did what's called a transforaminal epidural steroid injection. And based on these morphologic measurements of back pain, if you will, the patient did predictably well, at least we thought. So they reported a pain of 3, and then after the procedure and for 2 weeks after, they had no pain after we delivered some of the medication to the site. But take another example. Again, this happens every day. Here's a sagittal MRI in a patient. The left image is a T2 weighted, and this is a T1 weighted image on the right. Uh, on this, where my arrow is pointing, you see that this is a normal neural foramen where the exiting nerve root is surrounded by fat. Compare that to the neural foramen just above. There is no perineural fat. The foramen itself is compressed by some degenerative change, and the nerve is getting impinged here. So predictably, we were asked to inject this nerve root at this site to alleviate their pain. So that's what we did. Um, we injected the medication into that neural foramen shown here. You can see some contrast starting to outline that exiting nerve root and also get into the epidural space. But lo and behold, when we did the pain assessment, look at their pain scores, they came in with a pain out of 2, and in fact, their pain increased despite our injection going to the right place. So again, we have a very poor handle on what's causing someone's pain or what can even alleviate their pain. So uh, again, as I mentioned earlier, about 70% of those patients who have chronic pain fail to achieve any reasonable relief with standard of care management. So we need to do better. For a couple of decades now, I've been trying to work on how to image pain more accurately. So that's been kind of my job as an academic radiologist. Uh, Imaging methods that we use today are limited in their ability to accurately identify pain generators. And so I do think that some of these molecular imaging techniques, such as FDG PETMRI or FDG PET-CT, or followed by an MR, could potentially help patients. And so if you aren't doing this, I would encourage you, if you have a challenging pain patient, to do this. What's also very interesting, at least in our country, is that this FDG PET study is now reimbursed by insurance to image inflammation or pain generators. So that's been kind of a nice boon to the practice of doing this. So some emerging methods with PET-MRI. As you know, or many of you will know, that PET is about 1,000 to 200 times more sensitive than MRI for looking at inflammation. And PET has the potential to be more specific than MR, provided you pick an appropriate target. So in the pain world, you'll see sort of graphics like this, where you have a number of cellular as well as a number of molecular mediators, including a variety of cell membrane receptors and ion channels. So if these were any, and many of these are upregulated in the pain state at the site of pain generation, you could exploit this for your own purposes. Meaning if you develop a tracer specific to any of these entities, you maybe have a good shot at looking at pain generation or at the site of pain generation. So let's say if someone had spine pain in a particular location in their spine, this is just a cartoon showing you what the nociceptive pathway is. At the site of pain generation, you of course generate action potentials at the pain sensing nerve. That, of course, action potential travels up the cortical spinal thalamic tract into your brain, and then eventually your brain processes that as pain, but then your brain actually modulates that experience by trying to make you pull your, adjust your body position so that you're not in pain, or kind of compel you to take some action to feel better, sort of that sort of thing. A lot of really smart people and pain scientists have found there's significant biochemical, molecular, cellular changes at a variety of locations along this nociceptive pathway. But not only do you see changes in the nerve itself, but there are changes in the muscle, changes in synovium, blood vessels, innate immune system, a variety of tissue-specific peptides, cytokines, neuropeptides, all at that very peripheral site. So developing a PET tracer for that might give you an advantage in identifying a pain generator more specifically than what we can do today. So for example, let's say you did have a PET tracer that you were interested in, a nociception specific radio tracer, and let's say this patient had left foot pain, you would of course, in looking for a cause for that foot pain, you could systemically inject that tracer. Of course, it circulates around, gets to the target, and then you perform your PETMR scan, and the hope would be that this scan would reveal maybe the exact location of hypernociceptive activity. And in this example, I'm giving you that maybe it's in the knee and not in the foot, as you may have suspected. And sometimes we see that because foot pain can be referred from knee pathology. Of course, this would inform your management, and you may do like an image-guided injection of analgesic to that site, or local surgery at the correct location and hopefully get a good outcome. So that's kind of what we're trying to do. My group has been working on these uh, radioligands, if you will. FDG, of course, has been used for cancer imaging and staging, but now the FDA has approved it for the use of uh, unrealized areas of inflammation. So insurance now reimburses for that. So I've been repurposing FDG now that it's FDA approved for this indication. Sigma-1 receptor, I'll talk about later. This is a molecular entity involved in increased nociceptive activity and painful inflammation. I came to Wisconsin specifically to work on this one. I'm not going to show any examples of this today, even though we've done a couple of patients, but it's radiomanganese, which actually mimics calcium activity. So it's a great surrogate imaging marker of voltage-gated calcium channel activity. And I've worked or collaborated with people doing sodium fluoride and looking at bone turnover for that. There are also other agents that are actually been in humans already, but I haven't seen much literature just yet. Radiocane just completed its first human patients. This is a radiofluorinated lidocaine. So that anesthetic that you get at the dentist for dental procedures is now a radiofluorinated imaging agent. So they're hopeful this could actually image pain. TSPO, this is a microglial cell marker, also a macrophage marker. So there's some groups at least in the US, interested in looking at that as a pain imaging agent. COX-2 inhibitor radioligands have also been made. This TRP, or the chili pepper channel, some people call it. There have been some efforts to image that. substance P receptor was attempted by the company called Merck, but it didn't do well in clinical trials, unfortunately, because reasons not entirely clear, because they won't tell us. CGRP, bradykinin, or other targets that people have attempted. So I'm not just the only one. There's a number of other groups doing this. These are some of my favorite collaborators. This is Ali Parasta at University of Wisconsin, and Rihanna van der Heijden is a professor at Erasmus in Rotterdam, Netherlands. We're all using this FDG PETMRI to image pain. Again, reimbursable in the United States, so we're going to start seeing a lot of cases like this. About a year and a half ago, I was doing 1 to 2 a month, and now we're doing on average 1 per day of these imaging pain cases. Let's show some clinical examples. This is a using FDG PETMRI. This is a 61-year-old female with complex regional pain syndrome, otherwise known as CRPS, for 8 years following a motor vehicle accident. This patient's had surgery for thoracic outlet syndrome, but had limited benefit, now presenting with severe right greater than left upper extremity pain. This is their MRI, and you can see compared to the left side, the right side is a little bit narrow, but this was not convincing enough for the surgeon to do anything. Interestingly enough, this is their FDG PET image showing a screaming hot uptake of that FDG in the neural foramen as well as in the postganglionic nerve root. Compare that to the contralateral side. This is the fused image. This is just us making some measurements, and the SUVs, of course, they're just trying to see how relatively hot it is. So, but this led to the surgeon having increased confidence in the next step. So just increasing confidence in somewhat a costly and expensive surgery, as well as a surgery that can have significant morbidity, was important to have. So this was eventually performed, this anterior cervical discectomy and fusion, and this actually helped the patient quite significantly. Did PETMR help? As I mentioned, this person had CRPS, likely nerve injury from neuroforaminal stenosis. This was the ultimate procedure that was done, and the patient attained 80% relief following this. And so the benefits of doing PETMR in this case improved localization of their symptoms, increase the confidence for surgical intervention, and ultimately improve their outcome. Here's a different example, a patient with youngish patient with lateral foot pain years after tarsal tunnel surgery. So he had been struggling from doctor to doctor, trying to figure out what was going on. That's the story of many patients that I see. They've seen multiple doctors, gone to multiple clinics at different parts of the country sometimes. Ultimately, they get this scan, and then hopefully we can help. So this is with these PET MRs, we do something called MR neurography, just looking at not only all the other soft tissues, but we pay some closer attention to the nerves. And this is just an axial projection to this patient's foot. I'm just kind of letting it load in initially, but one of the things we can see is the tibial nerve here, and that tibial nerve will eventually split into the lateral plantar nerve and medial plantar nerve here. We notice that the lateral plantar nerve is a little bit bright right there, but here you can see them splitting, so lateral and medial plantar nerve, and then as it goes into the foot, we see that, sorry, this is medial plantar nerve, lateral plantar nerve shown here. So this was informative to the surgeon, but it didn't really compel them to do anything until they saw this PETMR image that I'll show here. So we see some physiologic uptake in the skin, and the range of the SUV that we're looking at is from 0 to 3 or 0 to 2.5. And that's how you can pick up all this activity. If you're visualizing these PET at a 0 to 10 scale, you won't see it. in the pain world, you really have to narrow that window. But notice this is abnormal activity in the kind of what we call the hind and midfoot right here. There's a very important hot spot right here. And that's enough for us, or at least me, to say that's abnormal. That shouldn't be there. And what it has done, though, is it really focuses my attention to this location. So what I'm looking for now is, why is there abnormal hotspot here? Well, one of the reasons is you can see a little bit of scarring and fibrosis from their previous tarsal tunnel surgery at this location. And that scarring seems to go up to this area where the plantar nerves are. So here in this next slide, I'm going to show some static images. So here we have the medial plantar nerve shown in pointing to green, and red is the lateral plantar nerve. And notice how this hot spot is abutting this lateral plantar nerve. And this patient has lateral foot symptoms, so this is all kind of coming together nicely. If you look on the MR image, normally these nerves should have nice dark perineural fat on this kind of fluid sensitive sequence. But this nerve right here has some intermediate signal material that's attached to this nerve. So that's probably the scar tissue that they sustained after the tarsal tunnel surgery. And as a result, that scar tissue, which is metabolically active, is involved in perhaps the patient's symptoms. It's probably tethering that nerve. So every time the patient takes a step, the nerve's getting pulled by the scar tissue and giving rise to that patient's symptoms. Here's just a sagittal projection of that. So medial plantar nerve on the green arrow and lateral plantar nerve red arrow, showing again a lot of the scar tissue that we see here on MR is metabolically active, but also intimately associated with the nerve that's likely giving most of the patient's symptoms. So again, just some more coronal imaging here showing we've lost some of our perineural fat. Unlike our medial plantar nerve, we have a nice dark rim around it, but this lateral plantar nerve has this intermediate gray material. We've lost this dark perineural fat around the nerve. So putting all this together, I think, increases the surgeon's surgical, confidence to now intervene. So did PETMR help? Yes, this person had lateral forefoot vein, fourth and fifth metatarsals, had tarsal tunnel release beforehand, but they weren't able to figure out what was going on. And then after the PETMR, it was determined they had tethering of the lateral plantar nerve. And the management now is to do what's called ultrasound guided hydrodissection. So you can actually put a needle into the foot and try to dissect some of that fibrosis off the lateral plantar nerve. We're still waiting to do this procedure. It's literally, this is a case that's very recent, so the surgery has, or the procedure has not happened. But hopefully aiming for a good outcome. Here's a third clinical example, again using FDG PETMR. This is a 34-year-old female who had bilateral hip arthroscopies within 6 months of each other. They had this hip arthroscopy for what's called femoral acetabular impingement, but the patient still was suffering from right hip pain after the arthroscopy, but no left hip pain after the arthroscopy. So this is a nice case to kind of compare what images should look like. So FDG showing very robust uptake, not only in the vicinity of the joint capsule and the right hip. This again is the symptomatic hip. There's also FDG activity beyond the joint capsule into the outside soft tissues. Compare that to the activity in the asymptomatic but post-surgical left hip. This is a more typical representation of a post-arthroscopic left hip, where you don't see as much activity. So please know this patient already had MRIs prior to this, actually had 2 MRIs, which were unhelpful in the patient's management. It was not until they did an FDG PETMR did they realize the extent of abnormal activity. Even on our own MR, this is a highly fluid sensitive sequence. You can see there's essentially no edema, which you would expect, but FDG shows a robust amount of FDG uptake. What's also interesting, though, the FDG kind of tells you where to look, like I've mentioned, and then you look with a fine microscope, if you will, with the MR and see if you see anything abnormal. And lo and behold, yes, there's this little defect in the joint capsule. So what's probably happening is there's a tiny little hole in the joint's capsule and the synovial fluid is leaking. And synovial fluid outside of the joint is actually quite toxic to us. It really needs to stay in the joint. But you have, similar to a CSF leak, this is a synovial joint fluid leak, where we see a lot of inflammation, not only in the joint capsule, but beyond the joint capsule into the extracapsular soft tissues. Just some other images on that symptomatic right hip showing you uptake there. Some of that fluid could get into the greater trochanteric bursa and seep into there, causing inflammation of that bursa. So a combination of things giving rise to the patient's very debilitating right hip pain. This, of course, spurred the surgeon to go in and repair that defect. And ever since the second surgery, the patient's doing very well. So again, persistent post-surgical pain following arthroscopy, had a pre-scan diagnosis. We was not known before the scan. There was a lot of confusion, a lot of MRs done, which were not helpful. But post-scan diagnosis is that the iliofemoral ligament, which is a component of the joint capsule, was insufficient. It had that little defect. And then the hip arthroscopy was done to repair the defect, and patient now finally healing, and all done because of this very helpful FDG PETMR. One of my students went to SNMMI and presented this paper on our early experience of managing chronic spinal pain, impact of FDG PETMR on management with chronic spinal pain. She's a great student, Fatima Rashidi. This actually won second place in the general clinical specialties. Basically, we took patients who had chronic spine pain that were referred for the study, did FDG PETMR, and then developed a report, and then eventually determined what the outcome was or what their pain score was before imaging and then after an intervention in some cases. So the intervention was based on the FDG PETMR in a subset of cases. So we had 28 patients. We lost 5 of these to follow-up, so we had 23 that we were looking at, some with neck pain, upper back pain, and lower back pain, and the numbers there. Did PETMR change management? It did in 19 out of these 23 and did not change in 4 of them. Most of them got an injection and one of them got a surgery. Here is how kind of a line plot of all the patients, showing you a dark black line as the average. So on average, patients went from almost a 6 out of pain to a little bit over a 3 on average. But as you can see, some individuals had very dramatic improvements in the level of pain in a subset of those. So 13 out of 19 patients reported at least a greater than 30% reduction in pain because of this imaging exam, which is quite dramatic. In the pain world, even a 10% reduction is considered important. So getting 30% is quite important. No patients resulted in worse pain, so the test did not cause more pain. So that was kind of nice to see. Otherwise, I would have felt bad about that. And then patients where it did not change management, as you expect, their pain kind of held steady. So somewhat of a kind of controlled group here, where the patient status quo was unchanged and their pain was unchanged at follow-up. So overall had a positive impact on pain score, and no patients were negatively impacted. This would identify unknown foci of pain generation, enable targeted interventions, and then no impact on the minority of patients. Limitations include this retrospective design, sample size, lack of control. I'm going to try to quickly go through this other tracer that we've been developing for a few years, the sigma-1 receptor radioligand. This is a radioligand that looks for the sigma-1 receptor extremely high sensitivity. Normally, when this cell is hanging out quietly, not doing much, the sigma-1 receptor resides in the endoplasmic reticulum, coupled to one of these important cell signaling channels shown here. These channels can be anything from voltage-gated calcium channels to NMDA, so on and so forth. So after a painful injury or something inflammatory happening, you get an upregulation of the sigma-1 receptor, and their role is to help transport all of these ion channels to the plasma membrane where they can affect their action. It itself is a receptor, so you can block or stimulate it with agonists or antagonists. So there's a lot of interest in that in the drug world. This is the small molecule that's radiofluorinated that has a high degree of specificity for this tracer. We did 190 patients when I was at Stanford. 75% of them had a change in management because of this PETMR study with this tracer. And at the time I left Stanford, about 44 of them actually had a significant improvement in their management, meaning their pain scores went down. So almost a quarter of them at least. But this was an evolving story since it takes time for patients to and take doctors to be confident in what to do with this. So here's a patient with this tracer, had upper neck pain, upper back thought to be neurogenic in origin. They had MRIs and EMGs that were non-contributory. This is her pain diagram. So on the back right side, she's just putting all these X's where she's having all her pain. If we look at the PETMR image, we see significant uptake in the neck muscles and also upper back of this tracer. Notice on the MR image, there's no abnormal signal, no edema or edema-like signal. Of course, the PET is picking up some abnormal activity. You can compare that to the contralateral side where she's asymptomatic and does not have any uptake there. Diagnosis was myofascial pain syndrome. So these are patients with trigger points. These are axial images showing you more details. Again, this fluid sensitive sequence shows no MR abnormality. So if we only did MR, we would say this patient is normal, but thanks to the sigma-1 receptor radioligand PET, we see a lot of activity in specific muscles. This helped direct trigger point injections using CT guidance a couple of weeks after the PET-MR. We did it at a couple locations. This was another location located at about mid-neck. Again, MR showed nothing, but the PET did, and if you superimposed it, we could exactly localize which muscle needs to be treated. That was also done with CT guidance in that upper right image showing you where the needle was placed. After the patient got off the table after doing these 2 injections, she's received maybe 100 injections prior to this by practitioner hoping to find the spot, but she got off the table and said, I've never felt this good after an injection. So did PETMR help? Yes, we had this diagnosis of trigger points in the very specific muscles, and that helped guide localization of the pathology and minimally invasive interventions using image guidance, and ultimately improved her outcome. Another example, patient with a knee pain after receiving ACL surgery. So they ruptured his anterior cruciate ligament, got it repaired, but still had very, very bad knee pain to the point where he couldn't walk. This is a very athletic 34-year-old individual, very upset. He thought the ACL repair, of course, would fix him, but he was getting worse. The surgeon who did the surgery said, I have nothing to do for you. Go to the pain clinic and get some drugs, which is sadly what happens in this country quite a bit. But this is the full body sigma-1 receptor radioligand image, and you can see the symptomatic knee compared to the asymptomatic knee is taking up a lot of this tracer. If we look at specific images, we'll see in the axial, there's a lot of uptake kind of in the joint space. These are sagittal images showing you uptake along this, what's called the Hoppe's fat pad. Some other images, some behind the joint. Some of this is also in Hoppe's fat pad. So a lot of uptake not in the bone or cartilage, but in the soft tissue surrounding the bones and cartilage. And what we decided this was something called arthrofibrosis. And in this case, it was very painful to this patient. The top row shows the scan we did when he was in a lot of pain. So he had 10 out of 10 pain, a lot of uptake in the joint, and then we convinced another surgeon to go in and remove all this tissue, which he did. And then the patient agreed to do that post-surgical image here. So we see all of that pain tissue on the bottom row appears to have been removed. And this patient had 0 out of 10 pain after this. In fact, he said, my knee is back to normal and in fact stronger than my other knee. So nice outcome because of this PETMR study. And this last case, this is a Sjogren's patient. This is a disease that's characterized by migrating extremity pain, dry eyes, dry mouth, an autoimmune disease. This is her pain diagram showing all the places that she had pain. The X's mean the pain she's having at the time of the scan, and then circles where she also has pain but was not that significant. At the time of the scan. So the left image is her full body sigma 1 receptor PETMR scan showing her light up. I put 2 asymptomatic patients just to kind of give you a comparison. Usually the lower extremities below the knee are also very, very quiet, meaning with regards to radio uptake, but you can see how much robust uptake is seen in her whole body. And all her MRs, which she's had many over the years prior to this, were all negative. So again, PET winning the day, if you will. These are just slices showing her shoulders, how much uptake there is diffusely. This is the base of her neck. Again, this fluid sensitive T2 flex, not showing any edema in this muscle, but the PET kind of dramatically picking up uptake. Her back muscles, this is her buttocks. Again, lots of uptake. Her thighs, again, the fluid sensitive MR sequence, not picking up anything. So she said, amazing results. I'm so happy to get these results. It's good for me to know that where I hurt was an imaging correlate and it's not at all in my head, as has been suggested. So a lot of these patients think they're going crazy or they're accused of being crazy, but now she had an objective kind of image of what she's going to. As much as I am sad that my disease is so diffuse, I know it's indeed real. You've helped me more than you can know, is what she said. So in summary, PET is very sensitive. It can identify things that MR can't, but MR does provide excellent anatomic detail and localization. So it can maybe give us some clue as to what's going on if the PET can point us in the right direction. These are a large number of individuals who helped me doing this, and thank you for your attention.
Thank you, Sandeep. It was excellent, actually, elaborative talk and something like new concept, which is like we never thought actually. What most of us know is like PET-MR is mostly for the diagnostic, and that too it is a very recent one, and very few centers are there globally.
Yeah.
So I just want like means very maybe a wrong question from my side, but like when you thought about this regarding the pain as a entity, because that is something like which has a lot of morbidities in different ways, especially related with musculoskeletal radiology and systems and joints. So do you had any sort of like opposition or something? What you, Sandeep, what are you going to do with this in initial stages?
Meaning, I'm not sure I follow your question. I'm sorry.
Yeah. So what I mean to ask you is like something when you started this,
Yeah.
when you started this initially,
Mhm.
so was means your team or your people surrounding you were like how motivating were they?
Oh, uh, I think no, I'm embarrassed to say I was the only person thinking of this. I was trained in radiology, but I had undergraduate degree in molecular biology. And I noticed during my radiology training that FDG PET was picking up things that we weren't seeing on MRI. So I thought, maybe PET is more sensitive. And then I don't know if you remember Sanjeev Sam Gambier. He was publishing some exciting work on using gene therapy and PET, using what are called reporter genes as a way of imaging disease. And so, with my background in molecular biology, I find that very fascinating. And then I was also doing musculoskeletal radiology at the time, where pain is a huge part of the practice. I would say 98% of our requests are, someone in pain somewhere, so we have to figure it out. And I felt we weren't doing a very good job. So I emailed Sanjeev Sam Gambier. I asked him, what do you think about using this for pain? And he said, I think that's a great idea. Why don't you come up to UCLA? He was at UCLA at the time, and give me a talk to my group. So I got very nervous, but excited. So I had 4 months to prepare a talk on it, and I gave it to his large group at the time. He had about 50 people in his group, and they all asked me some really good questions, including Sam. And then he helped recruit me to Stanford, where I eventually became faculty after my fellowships. So, and then he also went to Stanford as well. So that I think was a key component to this happening. Otherwise, um, I don't think anyone else was kind of thinking of that. I think a big reason why that is because I'm trained in musculoskeletal radiology, and as you know, radiologists don't really venture into nuclear medicine world much. But because of my background, I didn't have a problem accepting nuclear medicine as a modality. So hopefully that answers your question.
Excellent
Good,
talk.
good answer. Sorry, go ahead, Josna.
Excellent talk, Sandeep. I just had one question because with nuclear medicine going into therapy so much, the sigma 1 receptor imaging, does it have any role in drug development and future therapeutic applications in nuclear medicine?
Yeah, thank you for that question. That's great. There's actually a clinical trial using a sigma-1 receptor drug that helped treat people getting chemotherapy-induced pain and nausea, and it proved to be effective. So there are companies trying to make sigma-1 receptor antagonists that will help minimize pain. In fact, the tracer that we're using, as I mentioned in my disclosure, the company has picked it up. That small molecule itself is also an analgesic, since it blocks sigma-1 receptor activity. So yes, I wouldn't say it's a classic theranostic, not like in the cancer world, but it does have analgesic properties itself if delivered in high enough concentration to that site.
So it is an antagonist, the molecule.
Yeah, it's an antagonist.
Okay.
So there's some discussion to make a formulation of it that's long acting and that you would deposit there using, image guided techniques to the site of the hot spot and hope that it would treat the pain by slowly leaching into that area and blocking those receptors. So that's how people are thinking about this
Yeah.
drug.
So that's something to look forward to then, hopefully.
Yes, hopefully, yeah. Mhm.
Yeah, just to add to Sandeep, what you said, Sam Gambhir actually is a former president of ISNM, and these webinars are actually in his honor. So
Oh, wow.
this is the ISNM MISI webinars that are actually in honor of Sam Gambhir because he's been a strong supporter of it. So just to close the loop, as
Okay.
regards what you said about acceptance and being ridiculed, that was a very pertinent question by Sikandar. Nuclear medicine people are ridiculed a lot because nobody else understands it. And then a lot of times people need a structural correlate to act upon a hotspot they see in nuclear medicine. And the very essence of molecular imaging and nuclear medicine is to pick up abnormalities before there is a structural correlate, because it's at a tissue or cellular level. And it's hard to, I mean, in theory they understand it, but in practice they're like, what do we do with it? So I think your presentation is very pertinent in showing the power of hybrid imaging and outcomes as regards that. I trained with Dr. Alavi at UPenn 25 years ago, and if he hears your presentation, he'll be very happy because he's the strongest proponent of FDG on this planet.
Yes, he
And
is.
we were taught to read these areas of uptake as infection, inflammation, impending decubitus ulcers, muscle spasm because of pain, and we could pick up things that were happening with the patient because we looked at it as a whole body scan and not just cancer. And so we could say that, oh, this patient has back pain, his iliopsoas and spasm, and so on and so forth. So there are people who are aware of the potential of this. It's just nice that you are able to implicate it in a practical manner and deploy it for the benefit of patients. So that's where I think your entrepreneurship and Stanford background helped. I think is you could put it to practice, and I think you should convey that to others who can then try to help, because this is a big problem. Pain, as you said, is the very common, especially pelvic pain is also a big deal these days. And I think PETMR has the power to change things. I saw a lot of images of PETMR. Fortunately, at Emory, we do have a PETMR as well. But I was just curious whether you're doing whole bodies, because I'm assuming for reimbursement purposes, you have to do whole body scans and not just a regional, just neck or foot or something like that, correct?
No, we do a PETMR limited. It has its own CPT code.
Oh, you do PETMR limited, actually. Okay.
Yep,
And what dose do you use for the limited PETMR?
It's still 10 millicuries.
You still give 10 millicuries. Okay. And then these are billed as, because lots of times the billing indication is fever of unknown origin or infectious focus.
Yeah,
I guess you're using inflammation or infection/inflammation as the indication.
exactly. Yeah, we coach the referring physician to
Can somebody mute who is not talking, please?
Yeah, requesting all of you to mute except those who are speaking. Please.
so the
Yeah, sir.
the yeah, we have the referring physician order a PET MR and PET limited, and then a separate MR. So we actually get reimbursed for at least two studies. Sometimes they want more coverage on the MR, so we'll just take the PET to an extra bed or two. And for example, in the pelvis, we do lumbar spine and pelvis MR. So we get reimbursed for those two as well as the PET. I'm not sure if that answered your question, but yes, we do also coach them, unknown site of inflammation. And the word inflammation should appear in the requisition.
Unknown side of it. Okay. And I might touch base with you offline because we are expanding our PETMR program as well.
Okay.
We are doing maybe 15, 16 PETMRs a week now. So
great.
it's a robust volume, but it's still mostly cancer related or brain amyloid or seizure or dementia related.
Yep.
We haven't, so this would be a new avenue for us. And we just hired a MSK nuclear radiologist at Emory. So I think that this would be exciting times for us to expand in this area as well. So I might touch base with you offline.
Okay. Yeah, I gave grand rounds in Emory not too.
Yes, you did.
And okay. So I'm happy to help, as I said back then. So if you want to, I'm happy to help you read studies, all of that stuff. I'd love to help. So
Yeah, because most people don't read it at that high intensity, but they don't realize that superficial or smaller structures, you have to change your window and change your threshold. So I think there's going to be a little bit of a learning curve as well. But our orthopedic people are interested in collaborating with us because we've started helping them with spec CTs of bones and so on and so forth. So I think this would open up another avenue for us.
Yeah, I'm excited to help you guys. Yeah.
Sounds good. Great talk, by the way.
Thank you. Thank you so much.
Yeah, I
Thank you
think
for coming.
before winding up, I just want, like, how do you see the future of this? Because you have started, you have been like
Yeah.
giving talks and encouraging young guys, and globally you want to propagate this. So how do you think
Exactly.
you
Yeah.
can do it?
So, I'm excited Dr. Omo wants to do this, and I'm happy to help anyone. One little caveat, though, it takes 1 to 2 hours to read one study. It's a lot of data, and it's, as a musculoskeletal radiologist, we're doing the equivalent of a few MRIs within one patient, even though it may be only one order or two. The amount of territory we're covering and the degree of detail that we cover is the equivalent of 4 or 5 MMRs. But so the next step is getting AI to maybe auto segment the PET, and maybe the output of that AI would say, okay, look over in this location, focus your attention on this. Developing the training data for that is going to be daunting, of course, but I'm hopeful the way this gets disseminated is that I help develop a software which we can give to the masses, and majority of the reading will have already been done for you. You just need to kind of check as a physician, a radiologist, on the accuracy of that output. But commercially, currently, it's really tough to ask a radiologist or a nuclear metaphysician to spend 1 to 2 hours per study. So that's not viable, in my opinion. So software development using machine learning AI is the next step.
Yeah, that's a good thing actually, because it's a era of AI, and like we can't because whatever we are planning, probably somewhere somehow down the line, definitely we have to get integrated or doing work simultaneously, or taking help of AI in our futuristic patient care in every aspect.
Yeah.
So yeah, any questions, just ma'am? Or no, ma'am? So I think if we don't have any questions, so it was a wonderful session, Dr. Sandip. Hopefully, thank you. And it's amazing seeing a lot of work on this new front, because it will change the scenario, especially pain is something like you see any, not only MSK, musculoskeletal radiology, but each and every aspect. And most important, devastating onco settings, oncological cases, oncological patients. Well, this will be, I think, game changer in the patient management. So thank you for your excellent session today, and thank you all for having a patient listening and joining for today's session. So thank you all, and hopefully with this we'll be winding up. Thank you all, and have a good
Thank
day.
you.
And good night.
Thank you so much. Thank
Thank
you.
you, Sandeep. Thank you, Sandeep. Yeah,
Bye, Dr. Jetsa.
yeah, bye.
Yeah.
Bye bye.
Bye.